Good morning, everyone. This is JICA-hosted satellite session titled Bridging Cancer Care Gaps in Resource-Constrained and Conflict Settings. My name is Iko Takizawa. I'm a Principal Research Fellow at the JICA Research Institute, and I'd like to extend, as part of a local organization committee of this symposium, JICA is one of the partner in hosting this symposium, the first time in Japan and second time in Asia Pacific. So we really extend a warm welcome to everyone for joining this session. And this session is really focusing on the gaps we see in the cancer care in resource-constrained setting, particularly focusing on Africa and West African countries. As many of you know, the cancer is really increasing challenging as public health issues in low and middle income countries as well. But our understanding on how the patient who suffer cancer in those challenging settings is still limited, and we need a lot of researches as well as more active interventions to take care of those patients in need, and then also the family as well. And we believe that health systems or health policy and systems research has a big role to contribute to provide some solutions to this emerging challenge of cancers in resource-constrained countries. So I think we have a great panel of speakers today, and we try as much as possible to for this seminar to be interactive. So we have a first round of panel presentations, and then discussions with the floors as well as the people joining through the Zoom. And also then we have a second panel, and followed by the active discussion. So we really encourage you to actively engage in the discussion. So let me start introducing our panelists today, or speakers today. We have an excellent set of speakers from around the world. First, let me introduce Dr. Samiratu Wedraogo. She's a professor of public health from University Joseph Kizerbo, or former University of Ouagadougou from Burkina Faso. And she's also a co-chair of the research group focusing on the cancer care challenges in Burkina Faso. Thank you very much. And then we have another excellent presenter from Burkina Faso, Professor Sonia Kabore. She is head of the pediatric cancer unit of Charles de Gaulle Pediatric Cancer Hospital, as well as she has associate professor position in the University of Joseph Kizerbo. Thank you very much for joining. And we have Dr. Catherine Lam, Professor Catherine Lam from St. Jude Children's Research Hospital. She's the founding director of the WHO Collaborating Center for Childhood Cancer, as well as the director of the Health Systems Unit, as well as the director of the Asia Pacific Regional Program at the St. Jude Global. So thank you very much for joining us. She's a globally renowned specialist in the pediatric cancer. So, and also we have, Dr. Chika Kitajima from City Cancer Challenge. She's, I think this is also founding regional director for Asia for City Cancer Challenge. And I think she can introduce what City Cancer Challenge is and what City Cancer Challenge does. But it's a civil society organization focusing on promoting the cancer care in many parts of the world. particularly focus on the city as a unit. And also we have Dr. Akiko Ida from Ogata Research Institute of JICA. She's a senior researcher at the Ogata Institute, and she's currently leading our research project focusing on the cancer care in resource-limited setting. So without much ado, let me introduce or invite the first presenter, Dr. Ida, to give us a kind of overview of what we are trying to address.
Thank you, Mr. Takizawa. So I'm Dr. Akiko Ida, and I'm going to give a global overview of challenges and opportunities in bridging cancer care gap in low and middle income countries from health systems research perspectives. So this is going to be very brief. So today, cancer burden in poor country is a reality of everyday life. According to WHO, by 2030, 3/4 of global cancer deaths will occur in low and middle income countries. This is even more, further challenge for low and middle income countries which host refugees and internally displaced persons. Today, 85% of refugees and internally displaced persons live in low and middle income countries for more than 5 years. We know that from Ukraine to the Horn of Africa, refugees and IDPs with cancer and other chronic diseases have not been given enough attention to continue their care during their long journey. I have worked very briefly in UNHCR since the Ukraine war, and I saw that. Today we have guest speakers from Burkina Faso. Burkina Faso has 2 million people displaced internally due to conflicts. And in my research, we have been observing children and adults who had difficulty coming to the capital hospital to receive necessary care, so that their diagnosis and care have been seriously delayed. Mortality rates in those countries are very high. For instance, in Senegal, it is almost 80%, not only due to late diagnosis, but for various challenges at different stages of health systems. Cancer often leads to catastrophic health expenditure and poverty. Financial toxicity provoked by cancer care is a very serious issue. However, this issue has not been given enough attention in global health discussions. Challenges from health systems research perspective. We have very scarce evidence needed for cancer control in those countries. For instance, for Africa, only 1% to 2% of cancer research in the world is dedicated to African countries. Also, existing studies are distributed in an unbalanced way. I just give an example. This is part of our research. We looked at financial toxicity of cancer care in African countries. Most studies focused on 5 English-speaking countries, colored. And those were mainly on women's cancers, which is logical, but not enough. Also, I'd like to be a little bit provocative by talking about the mindset of gatekeepers in health policy making. Why cancer has not been attracting enough attention? I heard many times, cancer is a disease of rich people or rich nations, or cancer is too expensive. Cancer is a problem of old people. We should be focusing on children. But is that so? Cancer is causing premature deaths. Also, cancer is affecting children. So where are the opportunities? There are global policies which are already in place, however, are not being respected. to some extent. So WHO resolution, but most recently, I found it very encouraging that WHO Afro Office 10+, which addressed the integration of cancer care into primary healthcare systems. The World Bank is mentioning cancer control in their UHC efforts, which I wish to encourage more. Major journals such as Lancet or BMC this year, they are trying to cover the topics. So we have to create a momentum, and this session is part of that. So this is very brief, and thank you for your attention.
Thank you, Dr. Ide, for giving us a kind of overall picture of what we are going to address through this session. So, so the first round of panel is really focusing on what is the challenges and opportunities for cancer care in resource-limited setting, particularly in African countries. So I'd like to invite the next two speakers, Dr. Wedraogo as well as Dr. Kitajima, to give us some, the cancer care in general. What is the gaps and challenges? So first from Dr. Wedraogo.
Good morning, everyone. I would like to thank JICA for having me. I would like to focus on cancer research in my country, especially Burkina Faso. There are a lot of challenges, as Akiko introduced. You know that in West Africa, particularly in my country, Burkina Faso, there is double burden of disease, infectious disease. Like currently, it's the season peak of malaria and dengue. And these are infectious disease that occur quickly and that killed a lot of people quickly. So the government will be focusing on dealing with these diseases or preventing these diseases to spread instead of putting resources on cancer, which take time to appear and which kill slowly. There will be limited limited resources invested on cancer research, as you can see. And a lot, as a researcher, we see it a lot. A lot of the calls, a lot of the money that is available out there to do research are for infectious disease mostly. Although some of the infectious disease could lead to cancer in the future term. And as Akiko said, most of the cancer patients that are coming in our countries, in the hospitals, are those that arrived very late. And the diagnosis will be done late, and the chance of having good treatment and surviving cancer are limited. There are limited health prevention resources invested on cancer, and also screening. Like Burkina Faso was really in advance compared to other countries, because in 2016, the government had decided that cervical cancer screening and treatment of precancerous lesion is free of charge. But the reality is different. The reality is different because you can go to the healthcare centers and they will say that, oh, we lack speculum, we lack this and that, so it's not available. You have to pay out of pocket money. This is leading people not to have these services at all. I would like to, I think my slides will just switch. It was just not in good order. So let's talk about Burkina Faso context. For those who don't know, Burkina Faso have been placed in last year as the first country that have been impacted by conflicts. We lost almost 2,000 people from terrorist attacks, especially in the north part of the country. This is a country with 23 million inhabitants, and half of the population are female, like almost 25% 22% of the population. Half of the population also is young, more than half are less than 18 years old. The poverty rate is really high. 43% of the population are poor, really very poor. And when you look at the map of Burkina Faso currently, the red, really red parts are the area of the countries where there are continuous terrorist attacks, conflicts, people flying from these areas every time. And for now, we can encounter more than 425 health centers that have been closed. 300 of them are not working at all. Basic services like malaria care, maternal and child health services, and so on. And the country is affected, more than 3 million people have been affected by this situation. And you can see in here that we have the need, what is required to have really good health services in the country. And just only, I don't know, even not 10% of what is required is secured to provide health services to people. And these health services, as I said, focus only on vaccine, maternal and child health, taking care of those who have been victims of gender-based violence mainly. So, yet the country every day last year, in 2020, according to data, 39 people suffered from cancer in the country every day. Like it's 12,000 people a year. And out of these, 3 of the 4 people who had suffered from cancer died due to lack of treatment, a late presentation in treatment centers. And the quality of the services is really scarce due to late referral, late diagnosis, delayed diagnosis, lack of equipment and supplies. So these are the most prevalent cancer: liver cancer, breast cancer, followed by cervical, prostate, pancreatic, and bladder cancer. As I said, limited resources invested in cancer, gap in data collection. We have just one cancer registry in the main capital city, 10% of the population covered. So no data about cancer across the country. I will stop here since my slide was just not in the right order, and I will have chance to come back to continue. Thank you for having me.
Thank you, Professor Ouedraogo, for sharing the reality in Burkina Faso and what the cancer patients are going through. And next, we would like to invite Dr. Kitajima.
Okay, so I think I'm a computer illiterate, so I'm asking for the instruction to operate the slide. Well, thank you very much. I'm working with the Swiss-based Global Health Foundation called City Cancer Challenge. I'm going to introduce my organization probably in part 2, but we are working on narrowing the gaps in cancer care in the city setting in low and middle income countries. And then we are currently operating in 15 cities globally, and then 2 of them are located in Asia. So I think today I'm the only probably the panelist who doesn't have a research background, but I'm still hoping that I can contribute to the discussion from the implementer's perspective. Then I'm supposed to talk about, Asia, but the epidemiological picture, I think Dr. Alam is far better suited to present that. So I think I just go straight to the list of the challenges and opportunities. And then, this is the only slide, so don't, I'm not going to be very long. Okay, so these are the very high level, the list of challenges and opportunities. And that we sort of identified through our work with the city and in collaboration with the city that we go. So let me just, go through it. I think undeniably the biggest overreaching challenge in the region is a very heavy cancer burden. Currently, the region is harboring nearly 50% of global cases of cancer. When it comes to the cancer mortality, it's very close to 60%. Yet the access to the quality cancer care is limited. And then sometimes, this gap is persisting, even though the region is fastest growing, region economically. And then in some cases, the access gap is even widening. Why? There are many things, as you know. But some of the key bottlenecks are very closely associated with the weak or fragmented health system surrounding cancer care. So let me give you some example. The first of all, like a data gap. In the region, WHO at one point reported that not all the countries in the region do not have a functional population-based cancer registry. That has a massive implications because the data cannot really inform the national policy or the quality care in the correct way. And another thing is a lack of systemic approach. In Sequence work, every city we go, we do the needs assessment. And in every city, not only in the Asian city, what is emerging from the needs assessment is, for example, the non-existent or maybe low capacity multidisciplinary treatment team in order to navigate the patient to the optimum care or treatment in cancer. So this is another example in what is lacking. I think there are many things, again, that causes this problem, probably lack of the human resources, lack of the financial resources, or maybe lack of the training opportunity. But this comes out in almost every city that when we're talking about the gap. And then in a bigger picture, of course, the financial constraints. As you can see, I think in this, the whole conference, this is the only session, I think, about cancer. So I think, well, I'm from the infectious disease world with a bit of the fundraising background. So compared to that, I think that the cancer gap, especially in LMIC, is massively under-recognized. And then there's no sufficient attention. So that doesn't really lead to the fair investment. So I think, and then government itself on its own cannot really address this issue because cancer treatment sometimes, it's very, very costly. So, if we look at the spectrum of the cancer control, the early detection of cancer or screening or prevention has some attention. That's good. But when it comes to the care, palliative care, terminal care, nobody wants to invest in that. So the lack of resources and then skewed investment depending on the phases. So I think I only have 1 minute. But Asia is known as a region of opportunity. And the most notable is that Asia is a hub for technological advancement and innovation. And then also there is a growing regional collaboration. For example, national cancer centers in the countries in the region, they're working very closely in order to share the knowledge, best practices, and then providing training opportunity. And then also ASEAN, I believe, they have an initiative specific to cancer. And then another encouraging thing is innovative financing. The discussion around this emerging, then the good advantage that we have in Asia, in cancer care, is that we don't really have to start from scratch. I think we can learn from the predecessors and the examples already established in the communicable disease. So I probably stop here, and then maybe about the government commitment, I think I'm going to talk about it in part 1, but thank you very much.
Thank you very much, Dr. Kitajima, for highlighting some of the health systems challenges related to cancer care. Next set of the two presenters, I'd like to ask them to focus on some of the challenges related to pediatric or childhood cancer. First speaker will be Dr. Lam.
Good morning. We're so glad that you've chosen to come to this session on cancer and the intersection with health policy and systems research. So on behalf of my team at St. Jude Children's Research Hospital, We'll talk a little bit about the context and then the regional and global lens, and then just an example of a sample integrated action and an opportunity for us to collaborate further. So St. Jude Children's Research Hospital was founded at a time when childhood cancer was not yet curable. So most children were not surviving. From less than 20% survival, we have developed research to make sure that's now more than 80% of children can survive. And that was just within 40 years. Can you imagine what we can do if we can put our hands together to make this drastic outcome improvement possible around the world? Because the reality is, unfortunately, for most of the world, survival for children with cancer remains at 20%. So even though we know what needs to be done, this is not yet happening. So for St. Jude, we believe, as our founder said, that no child should die in the dawn of life. And so we have a $12.9 billion 6-year strategic plan that includes a focus on global outcome improvement. We call this effort St. Jude Global, and we have a St. Jude Global Alliance with more than 360 hospitals, 80 plus foundations, around 80 plus countries in the world across all 6 WHO regions. And we offer a lot of global goods, including free registry platforms, free assessments and training tools, quality improvement packages, all so that we can drive towards global progress. At the same time, to reach this ambitious goal of ensuring that we can serve every child everywhere, we also partner with various United Nations organizations. So as one of my hats, I'm the founding director of the WHO Collaborating Center for Childhood Cancer, and we also have agreements with multiple UN agencies. So as we started our work at St. Jude Global, we worked first within the Asia-Pacific region with many disparate countries, and initially just a handful. And now, as of today, we have more than 54 hospitals in 16 plus countries. And we realized the commonalities that in many of these settings, children were not able to start or complete treatment, even though, as I mentioned, there is curative treatment that is known, but there are many health systems challenges that affect their capacity to access care, and many of it is because childhood cancer is often not prioritized or budgeted for at the national level. So applying various health systems and policy research tools, we've tried to synthesize and mobilize resources so that we can have additional funding and make concrete improvements in access as well as in outcomes for children with cancer. So as an example, first we have to start with the diagnosis. So a few years ago, we started looking at the 1,000 plus recommendations that WHO has for essential diagnostics. And we tried to distill to the top 100 because frankly, 1,000 is just too many to ask governments to prioritize. And as you can see in the graphic, all the red are all the essential diagnostics that are not accessible in the public sector. So families, most of the time, are the ones who pay the burden by having to pay out of pocket for these essential diagnostics. And how many times have you heard governments say we're prioritizing essential medicines? How can they do that effectively if there's no essential diagnostics list, if there's no sense of what needs to happen first to make the correct diagnosis and risk assessments for our child? So we have also done global Delphi consensus studies to assess the top 10 that need prioritization, as well as the top 5 that have to be prioritized even in crisis situations, working with colleagues that unfortunately are in very constrained and crisis settings globally. We have developed a tool called C5, Country Collaboration for Childhood Cancer Control. 5 C's in the name and also 5 modules that teams can deploy. And we've set this up and co-designed it with collaborators in 28 plus settings across all 6 WHO regions. And what's great is we can assess multiple hospitals and organizations and national level priorities with the local partners. So when we have the reports that are co-designed, we're not handing these to the ministries at the end after everything is done. We're engaging them actually from the beginning with the clinicians, with the foundations, with the ministries, with the researchers, and designing these toolkits together, as well as the dissemination tools, working with WHO Pan American Health Organization or with ministries to translate these tools into action in a locally relevant way. We've also tried to engage policymakers, researchers, and practitioners to see the same data when they're all trying to come up against deadlines. And so we've applied the C5 tool to work with the ministry and the clinician teams, sometimes for over a year, so that we can really understand the needs on the ground and their driving change. Dr. Sajiva Gunasekara is here today from Sri Lanka as the national focal points for childhood cancer and with the Ministry of Health's Technical Advisory Group. And this was one of the activities, applying C5 together. And then now they have their first ever National Childhood and Adolescent Cancer Control Plan. At the same time, we want to learn across country settings. So we've come up with iterative frameworks and multilingual search tools so that you can do rapid as well as comprehensive policy analysis to see how to make the policies future ready, not just for the challenges of today. And how do we look across globally? So we've now screened across 5,000 plus policy documents over the past decade to come up with a curated set of 1,000 plus national policies in cancer and cancer relevant aspects in 46 languages and assessed some big challenges. For example, seeing that essential medicines are budgeted for in less than 10% of global policies. So this, we thought, was an excellent example of a policy challenge that needs action and cannot just be acted on by anyone alone in a particular hospital or a particular ministry. And so St. Jude has made a commitment of $200 million to establish the global platform for access to childhood cancer medicines with WHO, as well as working with UNICEF and PAHO Strategic Fund. And we want this to be the first non-infectious disease-focused global fund to make access to quality assured medicines for children in low and middle income settings. And we really are setting this up as a co-design platform so we can learn together. And this will need lots of health policy and systems research collaborations. So I hope that more of you will be interested to join us, and I'll share more in the next segment about ways to collaborate and to apply, hopefully with your help, health policy and system science to improve outcomes for children and adolescents everywhere. Thank you.
Thank you very much for Dr. Lam for sharing light on the kind of hard reality of the world that in the United States or high-income countries, 80% of the pediatric cancer survive, while if you look at the world, I mean, only 20% of the children survive that situation. So I think it's a direction, but also some of the kind of being a torchlight as St. Jude Global is doing. So thank you very much for sharing the light on that. This will the Dr. Kabore will be the last speaker for the panel one. She'll shed some light on the pediatric cancer challenge in the Burkina Faso.
Good morning, everybody. I'm not going to speak in English, but I think everybody will hear me through interpretation. So first, I would like to thank Jaina to have invited us here, and I would like to talk about child cancer in Burkina Faso. As you know, we do not talk a lot about child cancer, pediatric cancer. So the idea was to have a current situation, to know the challenges and the prospects. And as Dr. Drago has explained, the epidemiologic profile is different. We've heard a lot about malaria, about dengue, and a lot of money has been spent to fight against those diseases. But now we have more and more non-communicable diseases that are actually developing in especially cancer, child cancer, in a context that is actually a poverty country. So you have to understand that the morbidity or the mortality burden of cancer is actually affecting the health of population in Burkina Faso, especially in really vulnerable things. We have now the current situation. We have three levels. We have the first level, which is the health center. Then the second level is the region. So we have regional hospitals there. And then you have the third level, which is the university hospitals, which are in two main cities of Burkina Faso. We have 6 university hospitals, but only one that is really as a pediatric center, and this is where I work. So child cancer is taking into account into 2 units. One is one at Ouagadougou and the other one at Bobo Dioulasso. In Ouagadougou, there are 2 university hospital. So in one, you have the Burkitt lymphoma, which is taking into account. So at the Yalgato unit, it was the very first hospital in Haute-Volta, then to Burkina Faso. Then you have the second unit, which is Charles de Gaulle Hospital, which is mainly only for children, and we do also surgery for children. So in those 2 hospitals, you have the Burkitt lymphoma that is done, the retinoblastoma, also the Hodgkin's lymphoma. So this is really at Yaldago. And then at Charles de Gaulle, we have mainly nephroblastoma and leukemia. And these, and then you have the unit of Bobo Dioulasso that I took that has just been opened in 2021. Now let's have a look at the staff. In Burkina Faso, in all the country, you have only 4 pediatric cancer physicians, 2 at Yalgato, 1 at Charles de Gaulle, and 1 in Bobo. Of course, we have the help of anatomical pathologists, hematologists, radiologists, and also eye doctor, because you know also that when you do child cancer, you have to have all disciplines, all fields together. So we started in 25. And until 2023, we had a number of cases that has been increasing all through the years. As you can see, it started in Yalgado, then in Chaldago, as we started in 2010. And then you have in 2022, you have now the 3 hospitals. So Yalgado, Charles de Gaulle, and Bobo. So what are our challenges? The national strategy to fight against cancer is actually based on the health sector policy of the National Health Policy and the SDGs. It's going to be set within the PNDS plan, which is the National Plan for Economic and Social Development. And also you have another plan, which is the National Plan for Health Development, but it's ending in 2020. And therefore, through the Department of NCD's direction in the Ministry of Health, and with the collaboration of the International Atomic Energy Agency, we did an assessment of the national capacities and needs to fight against cancer. We've identified the priorities and we've determined some strategies. And then we need to have a leadership or governments for this. So we decided to accept the WHA resolution and set up a national program.
Thank you very much, Dr. Kabore, for sharing light on the very constrained situation in Burkina Faso. We have a little bit behind our schedule, but we would like to open up the floor for the discussion. And also, we want to try some Minty-miru. Yes, some technology to give it like a sense of interaction. So if you can join through this QR code or the access code, and I think the question is also provided in the Minty-miru. And while we have a first round of discussion here, you can answer your questions through the Minty-miru if you like. I think also those who are joining through the Zoom can also join this Minty-miru thing. The question is, what kind of gaps exist and where in your own country or setting? Thank you very much. So good. We have already some answers coming in. So we leave it like that. So let me start the discussion, first part of the discussion. And if there's any questions or inquiry from the floors, please raise your hand and ask the questions to the speakers. So while the audience is thinking about their questions, I'd like to ask probably Dr. Lam to be more like to give us more like statistics and numbers. I mean, what is the kind of length of needed for the patient, particularly in low and middle income country setting, to get the diagnosis first, and then after the diagnosis, then how long it takes for the treatment. I mean, those are kind of challenges because many of the health systems in low and middle income countries, also to some extent in Japan as well, I mean, the health system is kind of fragmented. And then, for the patient, the cancer patient, it is really, really challenging and difficult to navigate through the fragmented health system to reach the final, I mean, the goal of receiving care and treat it. So if you can shed some light on from the global perspective, yes.
Sorry, I'm worried my voice doesn't usually carry without a microphone, but thank you so much. I think there are a lot of opportunities for the 400,000 children expected to be diagnosed with cancer each year. And I hope in future health systems global sessions, there will be even more discussion around cancer, as we're currently working on a Lancet Commission for Cancer in Health Systems. And in 2020, we released a Lancet's Commission on Sustainable Pediatric Cancer Care, exactly to depict the needs that cut across the whole system, from diagnosis to treatment completion and survivorship, as well as palliative care, integrated as part of providing added layers of support for patients and families. What we realized was very often governments were investing in parts of this puzzle. So they might be investing in the treatment itself, or they might be investing in one aspect of surgical care, or they might be investing in one aspect of nursing training. However, we realized that there was very little impact on the global survival if we only invested piecemeal. And you would only bump the survival a little bit if you invested in access alone, or in diagnosis alone, or even in treatment alone. And only by investing in the whole system, thinking about it as a systems puzzle and seeing that comprehensive package, especially knowing that for some childhood cancers, you need to have treatment continued for 2 years. So if you've only allowed the family enough financial protection for them to go through the first 3 months of therapy, that's exhausting all the resources in the health system of all the providers, of the family's life savings, without actually saving the child. So we're hoping to change that conversation and the way that we approach childhood cancer care and cancer care as a whole by having the systems lens and perspective, and hoping that you will also join us in addressing these gaps as a broader community, because we think by addressing cancer challenges, we're actually solving for the bigger picture health systems challenges as a whole for other kinds of chronic diseases and non-communicable diseases as well. Thanks.
Thank you.
Thank you for the speakers for excellent presentations. So first, my question is to our colleagues from Burkina Faso. I think both of you mentioned that infection diseases takes priority in low and middle income setting, and often diseases like cancer are ignored. But again, as you mentioned, so investing in cancer now is an investment worth for the country in the coming days as the non-communicable disease burden increases. So how would you, as on-the-ground researchers, treating clinicians, take steps to ensure that there is health system inclusiveness and focus on non-communicable diseases? And then if we have time, the question is for Dr. Akiko and Dr. Chika to see what role can non-governmental organizations and international government organizations can play to enhance the profile of non-communicable disease investment in developing countries, so that it is seen as more of an investment rather than a burden for those governments and policymakers. Thank you.
Thank you very much. Just to keep out, because of the time, I think the second part of the last part of the question will be saved for the next panel because we talk about solutions. So the question to the Dr. Ouedraogo or Dr. Kabore about the.
I will share with you what we are doing on the ground to raise awareness about the need to invest in cancer research and the need to invest in early diagnosis and treatment, because when we started working in Burkina Faso on cancer, we have realized that when you Google on PubMed, research published on cancer in our settings, especially is, when you ask about cancer publication on conflict areas, you will see a lot of paper from Ukraine, from area, except from where there is more impact on cancer, of a conflict on the cancer. So we have a research group starting to support cancer registries, because we know that without registry, we don't have an idea of the burden of the disease. Just only 10% of the population is covered by a registry, which is not even working. It's just like data collection is depending on funding and stopped years, some years, and restarts some other years. So what we are doing is to test acceptability and feasibility of implementation of cancer registries in different regions of the country to really cover all the country and have an idea of the real burden of the disease. One of the examples I have is in the east part of the country, we were able to collect data on cancer for 1 year. We realized that we had 300 cancer, and only evidence that 48% of them have received care. So we don't know about those who have been diagnosed with the other part. Have they been treated, or what happened to them? Have they been referred to another level of treatment? Nothing at all. This is what the kind of study or research we are doing on the ground currently, to just give a sense of the burden of the disease.
Thank you very much, Dr. Wedrag, for shedding a light on the importance of research in changing the political or the discourse around the cancer care. Dr. Kabori, would you like to add some? Okay, thank you very much. Any other questions, final questions for the first panel? Thank you very much. So let us move to the second part of the presentation. Oh, yes. This is thank you very much for those answers in the Mentimeters. Lack of UHC access, dissemination of knowledge, affordability, lack of surgery, training. Those are the challenge, some of the challenges that identified through the Mentimeter vote. Thank you very much. I think this is pretty much resonate with what the research is finding also. Thank you very much. So let us quickly move to the second set of presentations to talk about the possible solutions. First, I'd like to invite, we change a little bit the order, and Dr. Lam, and then followed by Dr. Kabore to give us some idea of solutions from particularly practitioner perspectives. So Dr. Lam, please.
Thank you so much. And now I would like to touch on some global opportunities to work together to improve outcomes through health policy and system science. So briefly, I will touch on framing, training, equipping, and collaborating as ways towards inclusive and integrative health systems, and how we can really engage and empower champions. So at St. Jude, we're the first and only WHO Collaborating Center for Childhood Cancer, working on 3 main aspects of policy, innovation, and engagement. And we're also key technical partners through our Blue Sky proposal that we put through to establish the Global Initiative for Childhood Cancer, aiming to approximately double survival as well as improve quality of life and decrease suffering for all, so saving 1 million more children by 2030. And with this kind of ambitious target, we really need all hands in to support the work and to identify and meet the gaps. Our health systems unit supports various aspects from the strategic planning to monitoring and evaluation through to daily coordination. And together we've already met some key milestones that just a few years ago people told us were impossible, including having childhood cancer be featured at the United Nations General Assembly in 2018 and in 2023. We've tried to promote inclusive and integrative frameworks, so thinking about childhood cancer in a new way and making sure childhood cancer can be embedded when we talk about systems change. So this has included our Health Systems Plus framework, where we're centered on the child, but we've brought in the elements of family supports and community engagement alongside the traditional systems building blocks, and then incorporated these into the cure-all framework that we're now using globally. And so you might see in orange, for example, medical products and technologies in our Health Systems Plus framework is the same orange that we use for the R pillar of cure-all, and the orange items in our 10 cure-all core projects. So basically giving people a common scaffold, a common language to incorporate childhood cancer in systems thinking. And this has now also been used not only in national, regional, and global settings, but also for other conditions and sectors outside of childhood cancer. We've also tried to integrate cancer and childhood cancer into normative practice. And this has meant having childhood cancer be featured in sustainable development goals discussions, or when people are talking about big pharma and the need to improve medicines access for 1 billion, how do we make sure childhood cancer doesn't get lost? Or when we have big policy documents and framework documents from the UN, how do we make sure that childhood cancer is now included, starting from the WHO report on cancer in 2020 and the setting up of a cancer center, documents from IEA and WHO from 2022 and this year, as well as things like impacts review. As you heard from Professor Sanya, they can be really impactful when they're requested by a ministry to guide the next phases of cancer control planning. And now for the first time, we've had childhood cancer be headlined as part of these impacts reviews. So not only cervical cancer and not only breast cancer. We've also developed the first WHO fact sheets on childhood cancer and worked with multiple UN organizations to set up new systems of working with children with cancer. So for example, you heard also about the importance of registries, and we fully agree. And so St. Jude just celebrated the 5-year anniversary of working with IARC, International Agency for Research on Cancer, for an initiative called Child JICR, so that we can strengthen both population-based and hospital-based cancer registries for childhood cancer control. As part of moving forwards and thinking about the future now, we are also very committed to equipping the next generation of scholars. So St. Jude is also a graduate school. So now we're into our 6th cohort of students and equipping these health system scientists and scholars in activities like developing policy briefs, things that are not covered in traditional medical school or nursing school, so that they are empowered to look at UHC integration or referral pathways and systems in a new way. And we've also extended this to work with ministries in a program we called NCCP ICAIA, National Cancer Control Planning, Integrating Children, Adolescents, and Young Adults. It's a policy science-driven series in 4 UN languages with country case studies and lessons learned and resources. We'll be recruiting our next cohort soon, so welcome country teams with ministry support letters to join us. And we've been really gratified to see applications from all 6 WHO regions and to work with these programs over the last 2 years. And we think this is really important because a big challenge is that many countries do not currently have national policies or budgets that include childhood cancer. And most of the time, the panels do not include any childhood cancer researchers or practitioners. And so to make this difference, our series provides a structured way of engagement so that ministry-led teams can work together with other ministry-led teams to discuss practical scenarios, legislation changes, real-world ways to make practical change, connecting the ministries, the clinicians, civil society, and researchers together. So we're really excited to work together and have a more visible way of incorporating health policy and system science research. And so we've set up also NEXPOS, Nexus of Policies and Systems. So this is a global network, and we welcome you to scan the QR code and to join us or to invite other colleagues to join us. We're looking for all sorts of collaborators because we recognize to tackle these big challenges in childhood cancer, we need expertise from all fields. We need your ideas from mental health and from system strengthening. We really would welcome additional collaborative researchers because we're often getting asked by ministries to help with advisory work and with technical research, and our teams can only tackle so much, but with additional inputs, we know we can really change the way we think and do work together to improve outcomes. And so I will close with this mosaic from our hospital, and it spells out the word hope in many different colored tiles. And it just reminds me that when our hospital again was opened, when leukemia, the most common childhood cancer, was not yet curable, our hospital director said this was the biggest barrier to making change. The biggest barrier to curing children was because of the lack of hope. But today, we hope to be able to make that difference. And with all your different expertise, we hope to be able to spell out hope in many different colors and to bring hope, deliver hope to many, many more children all around the world. Thank you very much.
Thank you very much, Dr. Lam, for sharing literally the sign of hope to address this very challenging issue of childhood cancer. And next, I'd like to invite Dr. Kabore for sharing some her ideas or perspective about the possible solutions.
So I've made a current situation. So we've thought about the challenges. So what are now the prospects? Everything will be starting with the National Cancer Program, which is now established, and we've started working with it. And this National Cancer Program includes both adult and child cancer. The concern we might have is that the adult cancer will dominate it, because right now the national program is mainly based on woman cancer, and screening of the breast cancer or other cancer for women is now free in our health centers. So we hope that the child cancer will also have its own budget in this national project. Second idea is how much the UHC will be effective, because we know that cancer costs a lot of money, and our populations are not in a position to pay on the long run. So there's a problem of continuity, and the therapy is not actually done correctly, and you have a lot of people that abandon the treatment because of that. But the UHC will, we hope, help us in having these kind of disease being really cured. We've started the registration system with the UHC, and this should actually be increased by starting in 2025. So third prospect is the inclusion of pediatric cancer in free care, health care. It is not actually free healthcare. It just means that you don't have to pay for it. You're exempted for pay. Since 2016, we've set up the free healthcare for women and for children from 0 to 5 years old. But this free healthcare is only for communicable grave diseases, serious diseases. But the other diseases were not included in this free healthcare system. So before coming to Nagasaki, we took part in a workshop on including child cancer in this free healthcare policy. But it won't be all cancers. It will be starting with those that are the most frequent. So try to have also a follow-up and assessment, and then include the other cancers later as a second phase. So we have some positive prospects, but we need to have all stakeholders really involved. the whole community should really be committed. So researchers, clinicians, everybody should be really engaged or committed. It means that all steps also should be focused. We have Proverbs said that one hand cannot take all the flour. So it means that we need to work all together to have good results.
Thank you very much for sharing some of the very practical way of progressing toward kind of gradual universalism, starting from major cancer challenges, and then also the importance of kind of multi-sector and the whole of government approach. Now I'd like to invite Dr. Kitajima to give us from civil society maybe perspective.
Thank you very much again. Maybe I'll just, okay. So the City Cancer Challenge, I think instead of presenting the recommendations for the policy or strategy, I think I'll just introduce the model that we have been implementing. So in the hope that it could probably be, part of the solution and then can be replicable if you want to, use this model. So this is a little of the statistics. Well, I don't really want to get into details, but this is some output figure of activity. And probably more interesting is probably, the Second City Network. As I said, we are working in 15 cities currently, and the two of them are in Asia. One is Phnom Penh in Cambodia, and then another is Kuala Lumpur and its surrounding. We call it the Greater Petaling region. But we are trying to expand this network up to 20 cities by 2027, so that we can make more impact. So how just gives you the idea how our organization works, and then what is the model. So as you can see, what we are going to start, it's like the principle is that we always put the city stakeholders and cities in the driving seat. We are we catalyze and facilitate, but we support them, and then it's the city stakeholders are always in front. And we embed sustainability from the beginning. We don't go to the cities, we don't identify the cities, we make a call for applications, and then we do the due diligence, and then jointly select the city that we are going to go and then work together. And once the city is selected, all the following process, the stakeholder engagement and needs assessment, strategy building, and then also project planning and implementation. That takes probably 5 to 10 years altogether. That the cities are the center. This is the only way that we can ensure the sustainability of the activities after we leave. Yeah. So, this is what we are doing now. And then the two cities in Asia, are at the different phases. Phnom Penh is finalizing its needs assessment, and then we are going to have the outcome validation meeting early December. Then we proceed with the project planning, and then Greater Petaling is one step ahead. We are ready to do the project planning in these 10 areas. This is a template that we apply for everywhere. So this is what we are planning to do, the project planning. But before that, when the stakeholder is identified, the very first thing as a milestone that we do is to create the ecosystem of the cancer care stakeholders. It doesn't, it's not only the government or city, the health people, not only the public hospital, we try to engage with the private hospital, and also the civil societies, patients group, patient themselves, and then also those who are working on the health financing. And then sometimes, the private sector, for example, or the private insurance companies. So this is the key thing in order to, ensure the sustainability. And then also it's a very simple thing, but, in many countries, there's no avenue for those stakeholders to get together and they exchange their views. So I think creating this ecosystem and the center of the action for cancer care is the key. So these are the things that we are doing. And then after, so a little bit of the, and then why we select the city as a target of intervention, because we started very small. We started with 2 people. And now we have probably nearly like 50 in 7 years. So in the practical reason, I think we cannot really go everywhere. So we identify the viable unit where the basic infrastructure is there, and then we can make some impact. So that's the city. And then maybe I think it was the right choice, because by 2050, the 2/3 of the world population will reside in the city. So this is what we are going to do. And then from time to time, we embed the research project. Probably, I think it's really closely related to the theme of the session, because we are evidence-based, organization. So we work together with the local researchers in the country, but also, rely on the global network of the researchers, like, my fellow panelists. So research is playing a key role. For example, just recently with the King's College in London, we started the project to identify the quality cancer care indicators, because before many hospitals or their stakeholders are working, setting up the different kind of indicators, and then there were like 84 altogether, but we narrow it down to 18. So this kind of research project from time to time, inform the process of our engagement. So this is, I just wanted to, show our model. So probably I think we could work together if you are interested in this kind of approach, because currently we are not working, we are working with the city network of the Sikh cities, but probably in the future we'll go beyond. So in that case, I think maybe there's a possibility for further collaboration and the cooperation. So I'll stop here because the time is limited, but thank you very much.
Thank you very much, Dr. Kitajima, for sharing the activities of what city cancer does. And then I think it's one of the practical example of a gradual universalism again, starting from the city as a kind of a smaller version of a national health systems. So I'd like to invite Dr. Ider, followed by Dr. Wedraogo, to provide us with kind of a solution, their ideas of solutions from the researcher perspective. So Dr. Ida, please.
Okay, thank you, Mr. Takizawa. So I'd like to give some thoughts from research perspective, but also I'd like to mention a little bit about donor perspective, because I'm working with JICA research as a researcher. So what can researchers do to make a difference in this situation? We have talked about a lot of challenges on different aspects. So the first thing is, of course, we should be providing empirical evidence by collaborating with health professionals and policymakers in low and middle income countries. There's serious lack of evidence. And first of all, we need to be creating, we need to be working on this, and we need to be making this as a priority for research. It's not acceptable that 1 to 2% of cancer research is on Africa. This is not acceptable. We also need to advocate for the integration of cancer care into UHC efforts. As in the donor communities, all the donors are working on UHC right now, and cancer should be part of that. I must admit that policymaking is not always according to the evidence. So we need to pay attention to that. And therefore, the third point, we have to, as a researcher, we have to think out of the box. We have to question what is going on right now. Are we really making policy according to the evidence? So therefore, today we organize this session. We have to look at the reality and also give evidence, and then try to promote changes. I'd like to briefly answer to the question of Dr. Sanjeva that what the role that donors, external international community can play. also NGOs and others. I agree with the previous colleagues who talked about the importance of working together, different stakeholders working together to make a difference. At present, cancer is not the most priority global health issues. We have to admit that. So we have to bring all the efforts first together to make this change. Everyone has a role to play, but of course, the government of poor countries should be in the driving seat and take leadership. And then, currently, just about 20 to 30% of the national budget of low-income countries are financed by external donors. So against this reality, international community should be playing an important role. Unfortunately, it is only 1 to 2% of health public, public health spending financed by external donors is contributing to non-communicable diseases control. So cancer is rather small fraction. So being a researcher in donor agency, JICA, I also feel that I have to do more advocacy toward my colleagues. NGO play an important role. We have to inform people and policy, as well as policymakers and health professionals, that cancer exists, because many people do not know about it, and we have to start with awareness raising, and the community and NGOs play an important role. Also, the palliative care and spiritual care. Spiritual care, and we are also, some of us are working with traditional healers, because many people go there for the first consultation. So everybody should be involved and play a role. So this is all from me. Thank you.
Thank you very much for Dr. Ida. And then Dr. Ouedraogo, please.
Let me talk from my notes. So I think for Burkina Faso, as a low-income country and that is struggling with insecurity, there are a lot of opportunities for cancer control. First of all, it's important to develop population-based cancer registries, because without registration, without data, we cannot really know and have information about cancer in the country. It's important, for example, to also invest in having an idea of the economical and psychosocial impact of cancer on people, families, and also on the community. Because in my setting, in my country, cancer, a disease, is a problem for all community. So a lot of the families run out of money because they are investing in taking care of one cancer patient. It takes a lot of resources. It's out of pocket, and everyone in the family has to put money in to support the care of a member who is suffering cancer. And it's financial toxicity for the community and the population. It's important to explore the culturally tailored, low-cost awareness screening campaign, because there is lack of awareness about cancer in my country. Cancer is still seen as a witchcrafty, something, a punishment from God. So people don't really know that it's their lifestyle that is causing cancer, and exposure to carcinogenesis that is causing cancer. It's important to invest on raising awareness about the disease. Public-private partnership, because we know that we need a lot of resources for cancer. So the public sector alone cannot support all the costs. Private sector need to support and to invest. We need to strengthen this collaboration between private and public sector. Integration of care. A lot of resources are put on maternal and child health, infectious disease. Why don't we just integrate care so that the existing financial system integrates cancer prevention, cancer treatment in all what is already existing? accessibility of clinical trials. I don't know about a cancer clinical trial ongoing in my country. I don't know why. So a lot of clinical trials are ongoing in high-income countries, on some of the East African countries, but in West Africa, clinical trials are, especially on cancer, are lacking. So why don't we just invest on that? And also looking at local care, access to care, because we have medicines that have been developed by local researchers or local traditional healers. Why don't we just invest on proving that this work also, this can be used? This is endogenous treatments. Can we just invest on seeing what impact it has on people's life? And talking about that, in my country and in a lot of West African countries, cancer treatment is about medicines. It's about giving patient treatment. They are not focusing, for example, on supportive care, psychosocial supportive care, access to free space to have conversation between cancer patients, to talk about their struggle, to talk about their challenges, to share their experience. These are some supportive care that can be helpful for cancer patients. Also, simulating participation in social events for these people, because when it comes to cancer, it's about death. So they are just in the side and waiting for a time to pass away. No, cancer, there is a life after cancer. And I can relate to that because my own grandmother is a survivor of cancer. She is now 83, so we can survive cancer and we can have a good life after cancer. In my country, it's not seen like that. So awareness is really important. I will just finish my 43 seconds by asking to bridge the gap of cancer care in Burkina Faso. Strengthen primary prevention screening. Let me come back. Establish accessible navigation system so that cancer is diagnosed on time and care is accessible. Enhance capacity of health professionals working on cancer, improve health infrastructure, develop palliative care and psychosocial support, also support cancer research and data collection, establish public policies and cancer funding and support. Take-home message: effective and equitable cancer control worldwide required united approach, enhancing data, services, access and availability, and collaboration to turn the tide against this devastating disease. Thank you for your attention.
Thank you very much, Dr. Uedrago, for the excellent list of solutions as well as a very good take-home message. By the way, one of the reasons why JICA, together with Nagasaki University and other local partners, to invite this Global Symposium to take place in Japan, in Nagasaki, was that, we felt the voices from Asian Pacific, this part of the region, is underrepresented in the global health discourse. Even though we have a rich experience in health policy and systems reforms. But again, I think the voices from Western Africa, particularly the Francophone Africa, is also underrepresented in the global health discourse. So we really appreciate Dr. Kabore as well as Dr. Uedrago for being as a voice from the West Africa, particularly Francophone Africa, and enriching the symposium. Thank you very much. So the time is limited, but we try again the interactive question and answer sessions using the Mentimeter again. The second question will be a little bit long, but what expertise can your organization or can you offer to apply health policy and systems research to integrate cancer control into national health priorities? Because we need to really integrate the cancer control and the health priorities of the nations. How HPSR community or you can contribute to this effort? So please start voting. And if if it is also okay with you, please indicate your organization as well, so that we can have a follow-up communication based on this commitment, not commitment, but this. Yes. Thank you very much. Is there any questions from the floors? Or I think those who are connecting from Zoom can also post your question through a Q&A button. Are there any questions from the floor? How international CSO or the donor community can prioritize or support prioritizing cancer control? Yeah.
Okay, so I think Dr. Ida already partially answered your question, but from the non-governmental organization, what we can do is that, first of all, at the local level, as I said, we can probably facilitate the creation of the ecosystem of cancer care. But more globally, I think exactly the public relations, coming from the infectious disease world, I think the colleagues that much, much more aggressive. They have this weapon of messaging and, for example, especially that works is a return of investment. If we don't do anything now, what will be the consequences? And then that's very true, because I think nobody probably, deliberately talk about this, but the cancer is in every country, one of the top of the 5 cause of death. And then why we are not doing anything? I mean, so we have to strengthen this public relations and advocacy. And then, next year, there will be this UN General Assembly, and then there will be the high-level meeting on NCDs. And then if we miss that opportunity, I think probably the next one is very close to 2030, which is a deadline of the SDGs. So I think we really have to work together to put across the very strong message, and then we have to be prepared for that. I'm not really saying that we have to compete with the infectious disease world, but I strongly believe that the investment should be more balanced. So I guess, in order for us to put the message across, I think we have to work together. So I don't know whether I answered to your question, but thank you.
Thank you very much. So we have to keep in mind the UN high-level meeting as well. Any other questions from the floor or from the Zoom participants? Yes, please.
Thank you very much for those presentations. I would have some suggestions thinking about the proposals that were done for Burkina Faso, especially what Professor Cabrera said, including cancer, which are chronic diseases, and have it as a free healthcare or within the UHC. Will that be done based on a study? What would be the costing of that? Because usually for non-communicable disease, it's going to be a long time cost. So very often the decision makers, policy decision makers, think that it's going to be too heavy, too much of a burden on the public health budget. So in order to include it in free healthcare, I think it's a good idea. But how can we do that without giving some data, costing data, showing the idea behind it? So I think it would be very useful to have that data, that evidence, cost evidence, to do a lot of studies or research to show that maybe it's going to be a lot of costing right now, but in the long term, the results will be such that it will be useful and reduce the cost because it will improve health of the population. So we need to have costing evidence. Sorry. I am an economist of health. I I'm working with Joseph Kizan and working with the Montreal University. I'm preparing a PhD.
Thank you very much. Thank you very much for very good, insightful suggestions as well. And then, is there any response from? Yeah.
Thank you for the interest you showed in our presentation. So, including chronic diseases, so non-communicable diseases within the free healthcare package. I must say I didn't talk too much about it, but this will be done step by step. We asked to include what was already there within the hospitals, and then the government will actually make efforts what is not within the package right now. For example, in everything that is imagery, laboratory, so I mean the radiology and everything, we have most of it already in the hospital, so we're going to use that because it's already there. What is missing, what is lacking right now is basically medicine, so chemotherapy. And we ask the government to make an effort and to contribute to having this medical treatment through chemotherapy. And as you said, it's a very long-term chronic diseases, which means that there will be some choices to be made. We know that. And at one point, we'll make some selections.
Thank you very much. Very sorry, but I think this is a logistical problem. But so that the bilingual translation will be terminated. But if you, apologies, but if you have something to, add, Dr. Lam, please.
Thank you so much. I just want to also note that when we did the global costing and the global analyses, every dollar invested in childhood cancer at a systems level generates $3 in return. So I think it's really important to message that right now, a lot of the costs we are spending on medications or on care for the relapsed patient could be prevented if we invested in the comprehensive systems approach to begin with the appropriate diagnosis and full frontline treatment, and making sure that we're maximizing and optimizing those resources. But that if we invest wisely from the start and really have that package, that systems approach, then we have to just let our decision makers know it's every dollar, $3 in return. So this is something that will result in many thriving adults for the life course who can be productive citizens in society. And otherwise, these curable childhood cancers and these children are unnecessarily suffering, and we're actually wasting the resources if we just piecemeal invest a little bit of medicine, a little bit of diagnostic, but not enough to actually cure them. So we hope you will all be our ambassadors as the health economists and as the health policy and systems researchers in your different avenues of work to help us bring this messaging to light.
Thank you very much, Dr. Lam, for those. Actually, the investment for cancer control is really to produce the economic return as well. And then I'd like to add that the most of the cancer challenges, particularly in Africa, has the infectious disease. I mean, the infectious causes. So there is opportunity for infectious disease programs to work with cancer control. I think that's number one, and then also the importance of private sector, and then they're becoming more engaged in the cancer control as well. So I'm very sorry, this is very interesting. We want to continue the discussion, but the time is always against us, and we have to wrap up the session here and now. And thank you very much for excellent presenters, and please give them a big round of applause. And thank you very much for your active participation as well. Thank you very much.